All right. Welcome, everyone, and thanks for joining us tonight. I am Nick Hartog from Michigan State and Grand Rapids and Helen DeVos Children's Hospital, and I'm helping with the first case, and where we have one of my residents, Dr. Choi, who is presenting one of our cases, and then we are lucky enough to have Dr. Ballas from the University of Iowa, who's been one of my good mentors for a while, to help us as the senior mentor. All right, Dr. Choi, you can go ahead and start.
Okay, thank you so much, Dr. Hartog. Hi, my name is Patricia Choi. I'm a third-year internal medicine resident at Spectrum Health, Michigan State University. My senior mentor today is Dr. Zuhair Ballas at University of Iowa. And today we would like to present to you a case of a picky eater who developed altered mental status. Okay, I have no disclosures to share. So our case is about a 17-year-old male with history of failure to thrive, developmental delay, complex partial seizure disorder, depression, generalized anxiety disorder, food restriction behavior, who was admitted to pediatric ICU for acute altered mental status. About a month ago, he had a G2 placed for failure to thrive for severe malnutrition after minimal improvement with intensive feeding program. And of note, his tube feeds were started just prior to admission. So his story starts early on in his life. At 5 months of age, he was diagnosed with failure to thrive as his weight was less than 5th percentile. His mom states that he was constantly nursing and that he appeared subdued and had subdued reaction to the world around him. And at 9 months of age, he tested for celiac and cystic fibrosis due to his malnutrition. He was able to transition to table food okay, but he was always sensitive to highly textured foods like meat, and he needed supplemental formulas to help with his nutrition status. Despite his nutrition status, he was still able to reach his normal gross motor milestones. And throughout his childhood, he had a lot of misdemeanor and behavioral issues. At 10 years of age, he was caught starting bushfire, caught stealing. He was in special education classes, and he often refused to eat lunch at school. He was also noted to have frequent ear infections and had tympanostomy placed. At 13 years of age, he experienced his first seizure episode when he was hospitalized inpatient for anorexia nervosa. And he was started on an anti-epileptic drug. And a month after that, he had another seizure episode. At the age of 16 years, he had continued concerns for growth and development. And at this time, endocrinology was consulted, and he was started on growth hormone therapy. He was also enrolled in intensive feeding therapy, but unfortunately, both of these modes of therapies did not really work very well. So he was evaluated by GI for a possible G-tube for nutrition supplementation. Delving into his history a little bit further, so past medical history, again, he had failure to thrive, severe protein calorie malnutrition. He also has short stature, delayed puberty, seizure. He also, like I said, avoidant and restrictive food intake disorder. He also had generalized anxiety disorder and depression. Family history, he has two younger brothers, one who has food allergy. But in his family history, there was no concern for consanguinity or immunodeficiency. Surgical history, he did have, like I mentioned earlier, he had history of tympanostomy, and he had right femur fracture that led to open reduction surgery when he fell off of a tractor when he was playing as a kid. Social history, he's currently in an 11th grade and has no history of illicit drug use. On the third column, these are his current medications. He's currently on sertraline, aripiprazole, and carnitine. Valproic acid was discontinued about 2 weeks ago. So coming back to the ICU, his vitals were notable for extreme tachycardia at 149. His blood pressure was kind of in the soft range, but it was above 65. His temperature was normal. Initially in the ED, he was noted to be febrile, otherwise normal vitals. He was significantly agitated in the ED, and he required many people to hold him down. And on his physical exam, he appeared young and thin and had no facial hair. He was noted to have scabs in his lips and ears, and this was his mom stated that he often picked his skin when he gets nervous. His lungs and heart sounded normal, and his abdomen was normal, but was notable for the G-tube that was placed. And entrance of the G-tube site appeared clean, dry, and intact. Neurological status, again, he is alert but not oriented. He wakes up to stimulus and moves his extremities spontaneously, but he was not oriented. And he also had hyperreflexia and clonus bilaterally. So when he got admitted, toxicology was consulted, and at this time, the urine drug screen showed positive for sertraline, which he's already on for his home medication. EKG was normal with normal QTC. EEG was started, and it showed diffuse slowing, which was consistent with encephalopathy, but negative for seizures. On the third day, he decompensated significantly. He presented with posturing, stiffness, and unresponsiveness. His heart rate became very tachycardic to 197, and he had agonal breathing, and it was ultimately intubated. For his decompensated mentation, lumbar puncture was done to rule out meningitis or encephalitis, and EEG was resumed. He was also started on empiric antibiotics, and neurology and infectious disease team were consulted.
Patricia, I'm going to stop you right there and just say, do we have any questions right now before we go on to the next slide? I know you give a little more information about the presentation or anything about his history that anybody wants to know that hasn't been covered.
Yeah, this is Zuhair. A couple of questions. You said that he had frequent sinus and ear infections. Was that before or after he was on valproic acid? Because, valproic acid might cause hypogammaglobulinemia too.
So that was before, and it was a really kind of a vague history that they just said he would get sinus infections. I just had the one set of ear tubes that when those fell out, things were fine at the end. So it was it was earlier on in life.
So other than the seizure, did he have any CNS symptoms before this admission?
Not just the. Oh, sorry, I could say just the seizures, and then just kind of the behavioral oddities that Dr. Choi was describing is probably the other significant neurologic finding. Did I see? Oh, go ahead, Dr. Ballas.
You're going to tell us the CSF findings?
Yes, we're going to go a little bit more labs next. And then somebody was asking if he was specifically picky with protein. And yes, he was. And specifically did avoid a lot of red meats and protein specifically. So good question there.
Yep, all very good questions. Okay, so
Dr. Choi, go ahead on to the next slide.
Okay, so going more into his labs. So because of his acute encephalopathy and altered mental status, ammonia level was obtained from the first day of his admission. On the first day, it was slightly elevated at 83. At this time, he was so agitated, his 2 beats were held. And on day 2, his ammonia level went down to 28. At this time, 2 feeds were resumed. And on day 3, when he actually decompensated pretty significantly, his ammonia level went again up slightly at the normal range at 74. And day 4, his ammonia level went up very significantly at 181. At this time, 2 feeds were held again. And on day 5, his ammonia level went down to 33, and on day 6, it went up again to 83. Other abnormal labs were that he had normocytic anemia. His hemoglobin was at 9.7. However, his white count and platelet levels were normal. His ferritin and interleukin-2 receptor levels were elevated. Ferritin was at 1800. Interleukin-2 receptor was at 1300. Triglycerides were also elevated to 200s. Fibrinogen and immunoglobulin panel were both normal. For his workup, bone marrow biopsy was also done, and the pathology reading stated that he had mildly hypocellular marrow with trilineage hematopoiesis, and it also stated that hemophagocytosis was easily identified. CT thorax without IV contrast was obtained, and all different image angles showed that he had a ground glass opacification bilaterally, mostly in the posterior lobes, as you can see in the middle and the transverse cut, as well as the sagittal cut. At this time, pulmonology was also consulted, and they did a bronchoscopy, and the BAL did show elevated protein level, and the finding of BAL and CT thorax was both consistent with pulmonary alveolar proteinosis. So I think some of the attendees mentioned differential diagnosis already, but what are other differential diagnoses that?
Oh, Patricia, I was going to just stop you there and just expand on that. I know there's a couple people have said that inborn errors in metabolism and specifically urea cycle defects in kind of broad categories. And then lysonergic protein intolerance was brought up. And any other ones that people would be concerned about? I know this isn't always our necessarily a cup of tea and something we think a lot about, but I didn't know if anything else there would be on people's differential diagnosis or clues that are kind of pointing you in this direction.
So this is Zuhair. Let me just interfere a little bit. So you got HLH on this kid is 17-year-old, but so he has encephalopathy, which could go with HLH as well. Did he have any hemophagocytosis in his CSF at all? Did he have any nucleated cells?
He did not. He did not, and we didn't have the CSF in there specifically because it was completely unremarkable. Everything ended up being fine there, so he did not have any hemophagocytosis there.
Okay, and so he doesn't have any family history. So you're not thinking that this is primary HLH, obviously, because he has some other finding that makes you think of other stuff. So usually a 17-year-old, you're going to have to think of secondary causes of HLH. And so usually the big ones would be infection, connective tissue disease, autoimmune disease, or malignancy. Now you said they didn't find anything suggest malignancy in the bone marrow or in the CSF. The encephalopathy could be part of the HLH or could be part of his underlying disease as well. So, but now you said that the chest, he has protein alveolar proteinosis, right? So that kind of puts it in a different differential.
And what is that, when you see that finding, Dr. Ballas, where does that take you?
So, so you know, with the PAP, usually there is kind of either it can be congenital, which will be due to deficiency of GM-CSF, or it could be secondary to anti-GM-CSF autoantibodies, or it could be due to some kind of metabolic issues as well, which would be, somebody already mentioned that you have to do the urea cycle deficiencies in the differential.
Perfect. And then we have a couple other suggestions too that are kind of expanding outside of the metabolic disorders, including hypomorphic ADA deficiency, ZAP70 deficiency. Also, both those can present a little bit later in life too.
Did you have any flow cytometry CD4, CD8 counts on him, because that will help you out with the sum of the differential too?
So yes, we did, and all of that was normal. And I got it acutely when I saw him. I actually got it after I knew the diagnosis, so that was a little cheating. But then we have another comment: the chronic encephalopathic picture. So worried about neurodegenerative disorders. And do we have an MRI? And we actually did not during that time. All right.
And so you also have the hyperammonemia, which is, and he doesn't have any liver failure, right? So you have to think of other causes for that too.
He did not. And one of the interesting things that Patricia tried to highlight too, that was very obvious in retrospect, I don't think it was as clear in real time, was every time his tube feed started, his ammonia went up and he got encephalopathic.
Right.
And when he turned his tube feeds off, everything got better. And then GATA2 is also somebody just suggested. All right. And then Patricia, why don't you go on now at this point?
Okay, sounds good. Those are all great differential diagnoses. So the diagnosis was confirmed as Lysoneuric protein intolerance. So on next generation sequencing, 2 pathogenic variant of SLC7A7 gene was identified. SLC7A7 gene is associated with an autosomal recessive Lysoneuric protein intolerance, and this is protein metabolism disorder that leads to cationic amino acid imbalance or depletion. So patients with this genetic disorder has deficiency or depletion of cationic amino acids. So in their serum labs, you will see the low levels of cationic amino acids such as ornithine, arginine, and lysine. And then below in the tables, you can see what the patient's actual lab values were. So he did have very low levels of ornithine, arginine, and lysine serum levels. In the urinary labs, you will see increased excretion of these cationic amino acids. So for this patient, he did have normal levels of ornithine and arginine, but you can see very significantly increased level of lysine. And orotic acid is one of the byproducts of carbamyl phosphate. The other byproduct feeds into urea cycle. So orotic acid is also seen in these patients as high levels of orotic acid is seen in these patients in their urine. So what is Lysoneuric protein intolerance? So this is a autosomal recessive disorder caused by a pathogenic variant of solute carrier family 7 amino acid transporter light chain, or SLC7A7 gene. And this leads to defective Y plus L type amino acid transporter, or Y plus LAT1. And this is a catalytic light chain subunit of a heterodimeric amino acid transporter. As you can see on the right, the image shows the top part, the gray portion is the heavy chain, and then the bottom portion, the white portion, is the light chain subunit, and they're connected by disulfide bridge. This is another schema showing how the heterodimeric amino acid transporter appears in cells. So when the cationic amino acids come inside to the cell, it uses the heterodimeric amino acid transporter to leave the cell. So when arginine comes in, it has to go through the heterodimeric amino acid transporter with the Y plus LAT1 subunit to leave or exit the cell. So what happens when defective Y plus LAT1 occurs? So it basically leads to defective heterodimeric transporter. And this leads to decreased absorption of cationic amino acids and increased excretion of cationic amino acids such as lysine, ornithine, and arginine. And because these amino acids are precursors or substrates of urea cycle in the liver, basically the urea cycle is impaired. And so this leads to protein malnutrition. And so how does it present in patients? So in the beginning of the phase, when patients are at the infant stage, and as they are weaning from breast milk or formula to a more protein-rich meal, as they transition into more table foods, they will have recurrent vomiting and diarrhea episode, and they can also have stupor and obtundation. They will have aversion to protein-rich food and poor feeding, and that can lead to failure to thrive. And some patients may develop muscular hypotonia. And over time, these patients display more multi-system disorder. So they can have poor growth and developmental delay, as well as early osteoporosis. And oftentimes, endocrinology gets involved with these patients because of these findings. But there can also be pulmonary and renal involvement. Pulmonary involvement, like as you saw earlier in the CT thorax, patients can develop pulmonary alveolar proteinosis, which is basically proteinaceous material buildup in the alveoli, and that can lead to interstitial lung disease and later to pulmonary fibrosis. For the renal involvement, patients can initially have proteinuria, but then later they can have glomerular and tubular damage leading to chronic kidney disease and sometimes even ESRD. The immunologic part is where we come in when patients develop HLH. So as you guys already presumed, this patient has secondary HLH from LPI. So we kind of initially talked about the elevated ferritin level. It actually went up to 2000s at its peak, and of an elevated soluble interleukin-2 receptor as well in the 1300s. But he also met other criteria such as fever. He also has splenomegaly that was seen on right upper quadrant ultrasound. He also had cytopenia in at least 2 cell lines. He had anemia and neutropenia. His triglycerides were elevated to 200s, but his fibrinogen was always either kind of in the low range or in the normal range. And obviously he had the hemophagocytosis and the bone marrow biopsy, and his natural killer cell activity level was low. So currently the exact pathogenesis of HLH in LPI is not clearly known, but there is currently 2 schools of thought. One is nitric oxide dependent pathway, and the other one is nitric oxide independent pathway. The nitric oxide dependent pathway is thought to be due to defective arginine efflux due to Y plus LAT1 defect. And this defect causes intracellular L-arginine to be accumulated in macrophages. And this causes increased nitric oxide production from arginine by nitric oxide synthase 2. So it is thought that the increased nitric oxide level propagates the inflammatory process and immune dysregulation with increased cytokine production that leads to ultimately HLH. So the nitric oxide independent pathway, Rodoli et al. Showed in his study that when SLC7A7 gene is silenced, it induces pro-inflammatory pathway in THP1 macrophages, leading to increased production of IL-1 beta and TNF-alpha regardless of the arginine content. As you can see in the figures below, the x-axes are showing increasing arginine concentration, and the y-axes are showing mRNA expression. So, and the white bar is showing control group, and the black bar is showing the SLC7A7 silenced group. On figure D is basically showing that the SLC7A7 silencing is working. So that group with the silenced gene, basically the SLC7A7 mRNA expression is low. On figure E and F, what's showing is basically interleukin-1 beta mRNA and TNF-alpha mRNA expression, regardless of the arginine concentration, still has elevated production. So even at very low arginine concentration level, interleukin-1 beta mRNA and TNF-alpha mRNA expressions are elevated. So what is the overall management for LPI? So for the HLH portion, Anakinra is used for our patient currently. So Anakinra is an interleukin-1 receptor antagonist, and currently he's on the 3 mg per kg per day regimen, and he gets it as a nightly subcutaneous injection. For the metabolic disorder portion, he's currently on a management with G2 feeds that has protein-restricted diet. He also is on lysine citrulline supplementation as well as ammonia scavenging agent. So VP-CT thorax was obtained after being on Anakinra for about 2.5 months. So as you can see, pre-Anakinra, you can see the patchy ground glass opacification bilaterally. But post Anakinra, in 2.5 months, you can pretty much see almost all resolution of that ground glass opacification. This is another slide showing CT thorax in the transverse view pre and post Anakinra. As you can see in the pre-Anakinra, the posterior lobes had a lot of background glass opacification, which is pretty much all resolved in the post-Anakinra phase. On the bone marrow biopsy, the pathologist did remark that compared to the pre-Anakinra biopsy, post-Anakinra, the hemophagocytes are not as well identified and is less prominent. This is the hemoglobin and ferritin trend pre and post Anakinra. So hemoglobin initially, as you can see, when he was getting diagnosed, he dipped below 10. And then as he was diagnosed and was on the metabolic management, as well as an Anakinra, his level normalized and was sustaining at a normal level. And for ferritin as well, initially it jumped up to above 2000s. Once he was started on his LPI-specific management, as well as Anakinra, his ferritin level sustains at the normal range. And when he is on it regularly, he no longer meets the criteria for HLH. What's not shown here is that recently he became really non-compliant on Anakinra, and so his ferritin level shot up to 1300s when he was off of Anakinra. So the take-home points for this case: 1, Lysonergic protein intolerance is a multi-system disorder that can manifest early on with failure to thrive, delayed puberty, and neuropsych disturbances. But later it can present with pulmonary, renal, and immunologic disorders. Currently, the exact pathogenesis of how immune dysregulation process in LPI is not clearly elucidated, but it's thought to be due to nitric oxide dependent pathway or nitric oxide independent pathway. And finally, LPI is such a rare case, and there's currently limited resources on how we manage LPI patients, especially with secondary HLH. We wanted to share that interleukin-1 inhibition resulted in significant improvement in our patient who had the secondary HLH due to LPI. These are my references. Thank you so much for listening to this case.
Thank you. Great job, Patricia. Any other questions right now? No, we had one. Oh, yeah, Dr. Ballas, go ahead.
Great case. Did you consider, as you know, Nick, we have one patient like that also, too.
Yes.
And so she seems to be doing good on canakinumab, which way, since this kid is not going to be compliant, instead of having daily injections. If you canakinumab, you give it every 1 or 2 months, it might work better for him.
So we've discussed that and whether we should do it. We're in discussing with mom and him where we've decided not to pull the trigger has been solely based on insurance. The Anakinra actually went through shockingly smooth the first time. Although I should knock on some wood because he just got denied his re-auth today by chance. And so we have to go through that. So that's been the hesitation to make the switch. But it's definitely something we've talked a lot about and whether we should, but we have not yet.
Okay, so.
Any other questions or any other comments, Dr. Ballas?
It's fascinating that obviously this HLH in his case is because of macrophage activation, and as you know, a lot of secondary HLH are called macrophage activation syndrome. And actually, there's a mouse model where you can induce macrophage activation syndrome, like in mice, by giving them frequent injections of interferon gamma that you produce most but not all. What's fascinating though is that I'm still kind of interested in whether those ground glass appearance was actually part of the disease, or was that his PAP? Is his PAP improved on the Anakinra as well?
It has improved, and so our thought is that this is most likely the PAP that has improved. And so he is, pulmonary symptoms have gotten better. We have not bronched him, but a CT scan got completely clear because we haven't bronched just because there hasn't been a clinical reason more than just curiosity. And so our thought is that is what was driving it.
Yeah, I wonder what the mechanism is there for the PAP, but that's something to check at some point.
Mm-hmm. All right. Okay, well, I think it looks like that's about it. So great job, Patricia, and we will turn it over to Carolyn, who's got the next case.
All right. Well, thank you guys for that really interesting case. I know I certainly learned something there. My name is Carolyn Balo. I am going to be the moderator for the next case that we have tonight. And it's my pleasure to introduce Elizabeth Hicks, who is one of our allergy immunology fellows here at Duke University. And her senior mentor, Talal Mousallem, who is an associate professor of pediatrics in the Division of Allergy Immunology, also at Duke. And the case that they're going to guide us through tonight is titled A Case of T Negative, B Positive, NK Positive SCID.
Thank you, Carolyn. So as she said, I'm Liz Hicks. I'm one of the fellows at Duke. And we're going to discuss this case that's a bit unusual cause of T-B positive, NK positive SCID. So starting with the case presentation, this little guy came to us as a 3-week-old baby boy who presented with an abnormal newborn screen for SCID. He'd had a normal life until that point, normal prenatal and birth history, born full term, normal weight, hadn't had any fevers, illnesses, or infections. For family history, he was born to Yemeni parents who were first cousins, and he had 2 older brothers who were healthy. There is a family history of a maternal uncle and 2 maternal male cousins that died in infancy or early childhood of unclear causes. For his physical exam at this first 3-week appointment, he is above his birth weight and growing well. He does not have any syndromic features. He does have a superficial ulcer on his hard palate, and then this rash of scattered pinpoint yellow pustules on erythematous bases that is very classic for erythema toxicum. The rest of his exam was normal, and the rash and the ulcer did resolve on their own in the next couple weeks. Here's our initial lab workup. He had a normal white cell count with a low absolute lymphocyte count of about 1,000 cells per microliter. Our initial flow cytometry lab was done at 2 weeks, and it showed almost no T cells, normal number of CD19 positive B cells, and normal number of NK cells, or the CD16, CD56 positive cells. He had normal IgG and evidence of some IgM production with an IgM of 18, no detectable A or E. Infectious studies, the respiratory panel was positive for rhinovirus. We did do HSV swabs of that oral ulcer and one of the skin pustules, and this was negative. HIV and CMV PCRs were also negative. So thinking this was probably SCID, we started him on subcutaneous immunoglobulin replacement, as well as antimicrobial prophylaxis, and we asked the mother to stop breastfeeding until we knew her CMV status. This ended up resulting negative, but at that point, mom wasn't interested in resuming breastfeeding anyway. So I want to show you his flow cytometry results over the next few weeks prior to treatment. As you can see, his T cells, the CD3 positive cells, did increase in number, but they remained low, and he had near absent naive T cells. His NK cells, CD16 or CD56 positive, increased and were actually above the normal range, and B cells remained normal. His T cell function, as measured by proliferation of mitogens, was also quite low. So given these lab findings, we would say this is SCID with a phenotype of T-B positive, NK positive. Now, given that he did have those T cells, those mature T cells, we wanted to look for maternal T cell engraftment to see if these were maternal T cells. We did PCR analysis of the CD3 positive fractions on 2 separate occasions, and neither of those assays were able to detect maternal origins, with the lower limit of the study being 2%. So we tried a different method, and we did a FISH analysis of total peripheral blood mononuclear cells. These cells were taken following PHA stimulation. And this assay did find 6.5% of cells were female or maternal, but I will note we're not sure. We don't know if those are T cells or other sorts of immune cells that are female cells. Go ahead.
Yeah, maybe Liz, go back a slide. At this point, I would open it up for anyone who has any questions on the initial labs or the clinical presentation, as well as invite people to start thinking about a differential diagnosis, which Liz was going to help us with on the next slide there. And as a reminder, please just continue to keep using the chat function to put in your thoughts on a differential or any questions.
Yep. Do you want me to pause a second for people to come up with a differential before I show my differential?
Yeah, let's just pause for a second, let everybody think.
Or I'll go back to the one with all the immune labs.
So we have a pretty quiet chat at the moment. Now, I do see a question popping up here. Was CD127 or CD132 done by flow cytometry?
At this point, no. You're going to have to CD132 being the common gamma chain. And can you remind me which one CD127 is?
Right. So I'm seeing some things start to pop up here in the chat. We're getting a little more active. So I'm seeing IL-7RA, CD3 defects, IL-7. What about calcium levels? We see a lot of DeGeorge at Duke, right, Liz? What were the calcium levels like?
Yeah, that's a good point. So no calcium issues and no other congenital anomalies, no heart issues, no vertebral or other anomalies. Mom is not diabetic. Nothing syndromic about this child.
Yeah, and I need to remind myself what the CD127 is as well, but it looks like we've had a couple people help us in the chat here that is IL-7RA actually.
Appreciate it. Thank you.
And that, so that was not, we did not do that initially.
No. It looks like you guys, I'm going to go ahead. It looks like you guys are down the same track as us. So reminding SCID phenotypes, we often group them based on whether or not they have B or NK cells. So the most common causes of SCID in the United States being ADA deficiency, which is T minus, B minus, NK minus, and common gamma chain or IL-2 receptor gamma, or the CD132, as they pointed out, which is T minus, B positive, NK minus. You can also have SCID with no B cells but positive NK cells. And then we have our bucket, the T minus, BK, B positive, NK positive phenotype, which, as y'all astutely pointed out, tends to be defects in the CD3 complex, IL-7 receptor alpha, or CD45. So at this point, this is what we were thinking. So we did genetics next. We sent the Invitae comprehensive SCID and CID gene panel, and it came back with a variant in the IL-2 receptor gamma gene, and this is a gene that encodes the common gamma chain. It was a missense mutation with the alanine to valine substitution. The variant was not present in normal populations, and there was one other case of this mutation reported, and this patient also had a phenotype of SCID with a T minus, B positive, NK positive phenotype. So this was unexpected for us. This gene, when mutated, typically results in an X-linked SCID with an NK minus phenotype, whereas our patient had NK cells. Also, we were really thinking this was going to be an autosomal recessive mutation, given the family history of consanguinity, but noting that he did have a pattern of X-linked inheritance as well with the maternal male deaths. So since we weren't sure if this variant was pathogenic or not, we did family testing. We found that mother was an excellent carrier and that the allele was absent in the father and in his 2 healthy brothers. So this showed that the allele in question segregated with disease, lending support to it being pathogenic. So given his flow cytometry results supporting a diagnosis of SCID, the fact that this has also been reported in another patient with SCID, and his family testing proving that it co-segregates with disease, we decided that this variant was likely pathogenic and likely the cause of his SCID. So with that in mind, we moved to hematopoietic stem cell transplant at 7 weeks of life. We did not do pre-transplant conditioning, and we gave an unfractionated transplant without T-cell depletion. By 5 weeks after transplant, we were able to discontinue antimicrobial prophylaxis and immunoglobulin replacement, and he's now 1 year post-transplant. His T-cell counts have normalized, and he's continued to have a normal IgG off of replacement. We vaccinated him, and he showed a good response with positive diphtheria and tetanus titers. Those titers were drawn 10 months after his last dose of IG replacement. So he's continuing to do really well without any infections. Any other quick questions about his clinical course before I move into more the immunology behind this defect?
And Liz, we did have a question about some phosphorylation of STAT5, but we'll let you get to some of the later lab slides, and then we can circle back to that one. We did have another question about chimerism for him. I'm assuming these are probably chimerism post transplant now.
Yeah.
So
pre-transplant, we were not able to detect CD3 chimerism, but he did have the 6.5% maternal cells. Post-transplant, Talal, have we done chimerism yet post-transplant?
Yeah, it's his cells. Sorry, it's the donor cells. In
Which
terms
fraction?
of the CD3.
Okay.
CD3 fraction. Yeah.
And the donor was a matched sibling.
We have not done chimerism for the B cells.
Yep. So we've answered who is the donor, what are his chimerisms look like, and I think I heard you guys mention chimerism for T cells here, but you've looked at chimerism for other cells, correct?
No.
Or you've thought about it at least.
Yeah. Well, yes, but what we looked for was the CD3 fraction only, and it was donor.
Okay.
And then going through the other questions, donor was his sibling who did not have the allele. So he was not a carrier. He was male, and it's an X-linked disease. And then the A156V is reported as likely pathogenic now. When we ran the test, at least through Invitae, it was variant of unknown significance. I think when we got back to them that this was a second case of it is when it was changed to likely pathogenic. Talal, is that right?
Well, they knew at the beginning, like in the first report, if you recall, Liz, they did mention that there was another case. However, it wasn't until we did the family testing and we demonstrated co-segregation of the defect, like the mother was a carrier and the healthy siblings and the father did not have it. It was not until then that the report changed to pathogenic variant. So that's there was another case, but like we studied the family as well. And that's when after we sent blood on the other family members, that's when the updated report came.
Yep. And as for those original cases, there were the ones that are in ClinVar. There were 2 related siblings, one of who has passed away, and the other whom is still living. That are the 2 variants that are in ClinVar. Great. And then in terms of what we have in the literature, it's super, super sparse, but Liz is going to tell us the little bit of clinical data that there is available in the literature.
So I'm first going to talk about the common gamma chain and sort of explain why this typically results in SCID. So as you can probably recall, the common gamma chain forms part of the receptor for many different cytokines. Some pertinent ones are IL-7 is required for T-cell development. IL-15 for NK cell development, IL-4 and 21 for B cell function, but not necessarily development. So because of this, you typically get a T minus, B positive, NK minus phenotype with this mutation. So the question is, why does our patient have NK cells? And if you start by looking at the IL-2 receptor gamma gene, our mutation, our missense mutation, is at the end of the third exon. This is part of the extracellular domain that is involved in cytokine binding and associating with other co-receptors. Looking at the other two publications about this mutation, so it's been reported in one other case of SCID, but been published in two separate papers. Ishii et al. In 1994 did a case series of 3 patients with X-linked SCID, and then Kumaki et al. In 1999 delved a little deeper into this one patient, looking at the immunology behind the A156V mutation. So this patient, similar to ours, had no T cells, but normal B cells and normal NK activity. He also presented with a classic phenotype of SCID at about 3 months, but died shortly after prior to treatment. Looking at the first paper by Ishii et al. In 1994, they took this patient's cells with the A156V mutation, and they immortalized the B cells with EBV. They then showed that these cells had normal levels of mRNA expression of the common gamma chain. They also had normal expression levels of the common gamma chain on the protein surface. Where they did find a defect is in the ability of the common gamma chain to bind to IL-2. And on the right here, you see the flow cytometry showing normal expression levels of gamma C on the cell surface. So moving to the next paper by Kumaki et al. In 1999, they looked at the ability of this allele to transduce cytokine signal. So if you remember, when the cytokine interacts with gamma C, this is transduced through phosphorylation of JAK3. So they transfected a T cell line with either the mutant gamma C or the wild type gamma C, stimulated with different IL-2 family cytokines, and then measured JAK3 phosphorylation. So looking at this plot here, you can see that the mutated gamma C construct is in the right-hand columns. And you can see that the mutated gamma C was able to phosphorylate JAK3 in response to stimulation with IL-2 and IL-15. It had diminished phosphorylation when stimulated by IL-4 and IL-7. So summarizing the takeaways from these two papers, this A156V mutation results in X-linked SCID with an NK positive phenotype. With this mutation, you get normal expression of the gamma C chain on the B cell surface. And the literature reports that there may be a selective impairment of this gamma C to signal through IL-4 and IL-7, but relative sparing of IL-2 and IL-15 signaling. So what we did, and then pontificating on why this might be, if we look at the structure of gamma C, you can see that the arginine 156 residue is sort of in the elbow of gamma C near the cytokine binding region. So you could theorize that if we change the conformation of that cytokine binding region, that it might lead to this differential impairment in cytokine binding.
And
so next, go ahead.
Pause there just for a second, and I'm going to actually ask Talal. So Talal, thinking that our patient had what looked like an X-linked family history, you're seeing something in the literature that looks X-linked and similar. How did that impact your choice for who was going to be the donor for the transplant, and what sort of evaluation that donor underwent?
So excellent question, Carolyn. So basically, initially we were thinking that this was going to be an autosomal recessive pattern of inheritance, given the the parents being first cousins, and the history wasn't clear initially in the initial visit about the early male deaths. This came later, really, after we got the result. So I was actually very surprised when we got the gamma chain defect on the NVT panel. Now, knowing that there's consanguinity in the family, obviously we decided to do Hla typing on everyone, the mother, the siblings, and the father, and we were hoping that maybe, given the consanguinity, that we would have a higher chance of having an HLA identical donor. And this kid was lucky. He had two siblings that were HLA identical. His mother was half a match, and his dad was half a match. But he had two siblings that were HLA identical on class 1 and class 2. And we ended choosing the younger sibling, actually, because his flow looked impeccable. And he had a lot of naive T cells. And yeah, we ended up choosing that donor.
All right, thanks, Talal. I just want to make sure we really delved into that a little since there were some questions about it. So Liz, if you'll continue.
Oh, and he got the regular screening, any donor in terms of virology screening and all of that. And because we knew we were gonna, when we got the initial results that he was HLA identical, while we were preparing for the approvals and stuff, we made sure that the kid was born in the fall, winter. We made sure that the donor was vaccinated with the flu, in the hopes that we were going to be able to pass some passive, immunity in terms of using unfractionated marrow.
So moving on to what was done with this patient's cells. So we collaborated with Dr. Christina DeParis, who does a lot of phosphoflow cytometry at the University of North Carolina. And we wanted to look for evidence that the NK cells that he does have are functional. So in addition to the gamma C receptor, the IL-12 receptor is also important in NK cell function and cytokine production. So similar to IL-2 family, IL-12 signals through JAKs and STAT. The IL-12 receptor signals through phosphorylation of STAT4. So we looked at STAT4 phosphorylation as evidence of IL-12 signal transduction. So Dr. Christina DeParis isolated the patient's NK cells before transplant and stimulated with either media or IL-12. The media stimulated is the gray histogram in the top figure, and the purple is the IL-12 stimulated cells in the top diagram. And you showed that there was a very nice response with STAT4 phosphorylation in response to IL-12 stimulation. We did similar experiments to look at signaling through CD16, which is involved in NK cell activation. The NK cells, when the CD16 receptor is stimulated, it transduces signal downstream through phosphorylation of CD3 zeta, and then SYK and ZAP70 phosphorylation. So we stimulated patient NK cells with either CD2 or with the combination of anti-CD2 and anti-CD16 antibodies, and showed that they did increase CD3 zeta phosphorylation when stimulated with anti-CD16. And you can see there's a small second hump to the right of the histogram on the right-hand slide, and it is small but significant. And then similar results looking at SYK and ZAP70 phosphorylation. You get a small but significant increase in phosphorylation after stimulation through the CD16 receptor. So take-home points and summarizing what we talked about with this patient. We were not expecting X-linked or common gamma chain SCID in this patient due to his NK cell positive phenotype and the parental consanguinity, which made us lean towards autosomal recessive inheritance. But noting, as Dr. Rawat said, that you can definitely get X-linked disorders in this population as well. And he had a history that was suggestive of X-linked inheritance. And this highlights that a patient's immune phenotype does not always correlate perfectly with the patient's genotype. And this particular mutation in IL-2 receptor gamma results in an NK positive SCID phenotype, where the cells are still able to express gamma C receptor on the cell surface, but might have a selective impairment in IL-4 and IL-7 signaling, with a relative sparing of IL-2 and IL-15 signaling. And our preliminary studies have shown that the NK cells are likely functional with intact signaling through both IL-12 and the CD16 pathway. And then in the interest of time, I'm going to skip our future directions slide. So I'll pull up my acknowledgements and then welcome any questions. Thank you especially to Dr. DeParis and Ryan Tuck, who did all the phosphoflow work, and to Dr. Buckley, Dr. Sleesman, Dr. Ballo at the Duke Allergy Immunology Department, and Dr. Parikh, who I saw is signed in here. Thank you for joining, Dr. Parikh, who was with us when this patient was originally transplanted and took care of the baby's transplant. So thank you.
Wonderful. And then maybe, Liz, if you'll go back and just put up the slide that you glossed over for the sake of time. And I would certainly invite anyone, of course, to ask any additional questions they have regarding this case, but also what other thoughts folks have in terms of future investigation to better understand the genotype-phenotype correlation that we're seeing with this particular case. I'll just, okay, so we have one comment here that there's actually a Pro58 SEER IL-2RG variant that results in normal T-B and NK cells. And I think, you know, that's a really an important take home in relation to this case, that we do see from time to time that our phenotype by flow with SCID doesn't necessarily match the expected genotype that we think we're going to get. So we should always keep an open mind when things don't fit perfectly. We do have a question here. So Liz and Talal, would you guys be inclined to use GVHD prophylaxis in NK positive SCID?
We did not in this patient who had a matched sibling donor, but I'll leave it to Talal on whether he would otherwise.
I mean, you know, the NK phenotype SCID patients, not this patient, but the NK phenotype SCID, like the Artemis patients and the RAGs, you know, you could argue that you should, or you may want to consider giving those patients, reduced intensity conditioning, because those patients have shown that they're difficult to engraft. But we knew the molecular defect of this patient, that this was common gamma chain, due to common gamma chain defect. So I think knowing that those patients, many of them do well with this type of transplant, we decided not to. And basically also we had an HLA identical donor.
Yeah, and so I think, you know, there's sort of another follow-up here, you know, really emphasizing the fact that it wasn't just that NK cells were there, but they were also functional. And Suhag has also contributed in the chat his thoughts, which were for HLA identical siblings, GVHD prophylaxis is generally not necessary. NK positive may be more of a concern with regard to engraftment. But again, the emphasis is really that there was an HLA identical sibling, and that's really what made the difference in being comfortable going without the GVHD prophylaxis.
Exactly.
Wonderful. Well, thank you, Liz and Talal, for the really interesting case. Oops, one more question. Cell dosage. Ooh, do you guys remember?
I'll pull it up real quick. It was on one of the early slides.
It was.
But
yeah, it's on one of the slides.
I'm just pulling it up real quick. So it was 24 times 10 to the 6 per kilo CD34 positive cells.
Thanks. All right. Well, again, thank you, Liz and Talal. And I'm sure I can speak for myself and Liz and Talal that anyone who has any additional questions or thoughts or suggestion in follow-up of this patient, we'd certainly be interested to hear from you via email. And I'd like to thank everyone for participating in this conference, especially so close to a holiday weekend here in the United States. I'll also just remind everyone that these webinars are held once a month by the CIS Early Career Immunologist Committee. And so if there is anyone who is interested in presenting a case, maybe you attended a summer school and you had a really interesting case you'd like to share again, or maybe you just have had a really interesting case at your institution, please feel free to go to the CIS website and submit a case to present. And with that, I will say thanks again to everyone and have a good evening.
Thank you, Carolyn. Thank you, everyone.
Thank you, everyone.